I want to thank the organizer to give me the opportunity to present my work entitled Transcriptomic Modification Induced by the First Cycle of Neoadjuvant Chemotherapy Impacts Response to Treatment in Triple-Negative Breast Cancer. This is my disclosures. So I work in Centre Georges-Francois Leclerc that is located in Dijon, France. Dijon is the capital city of Burgundy that is famous for mustard and wine, the best wine of the world. CGFL is a comprehensive cancer center that has a molecular biology unit that I'm in charge of. This unit has three main activities. A routine diagnosis activities with the analysis of more than 2,000 tumor samples per year based on RNA-seq and DNA-seq by the use of different custom NGS panels. We also analyze more than 1,800 germline samples to detect predisposition to breast, ovary, prostate, digestive tract cancer, and we use a custom NGS panel for this application. We also have a routine whole exome sequencing activity with sequencing of more than 1,000 tumor sample per year. That represents about 500 tumors as we sequence tumor and its match germline DNA. Finally, the third activity is the research and services activities with whole exome sequencing, total RNA sequencing, single cell RNA sequencing, and so on. For all these activities, we have a lot cutting-edge devices. So triple-negative breast cancer represents around 15% of all breast cancer. This type of cancer has a poor prognosis despite neoadjuvant chemotherapy use, has non-responders, have between 25 to 40% risk of relapse at 5 years. There is no targeted therapy in this disease, and the only survival marker is the pathological response according to Chevalier classification. So we need to early detect non-responders. 11 years ago, Romain described different molecular subtypes. 7 molecular subtypes were described. There were unstable, basal-like 1, basal-like 2, immunomodulatory subtypes, mesenchymal-like, mesenchymal stem-like, and luminal AR. So these different subtypes have different signaling pathway activated. The BL1 has activation of cellular proliferation and response to cellular damage pathway. BL2 has growth factor signaling with myoepithelial markers. IM subtype has signaling mediated by immune synapses. M subtype have MET and differentiation activation pathway. MSN has an activation of MET, differentiation and stem cell potential, angiogenesis, and growth factor signaling. LAR has hormone signaling mediated by androgen receptor, and the unstable subtype has cellular proliferation and response to cellular damage. Transstep is a clinical trial that was opened in January 2015 and closed in October 2017. 20 patients were enrolled in this clinical trial. All had stage 2 or 3 of UICC classification, except stage T4D. They all received neoadjuvant chemotherapy with 3 courses of epiribicin plus cyclophosphamide, followed by 3 courses of docetaxel. There was no dose-dense chemotherapy, and all patients had 2 FDG PET exam, 1 PET at disease extension assessment, and the other one 3 weeks after the first course of EC, just before the second course. For this trial, we had two samples. The first one is a sample used at the diagnosis stage, and we obtained a second sample 3 weeks after the first course of EC, just before the second course. The second sample was obtained during installation of a clip. A clip is a small iron piece that we put into the tumor to detect tumor nest at surgery in case of complete tumor response at the end of neoadjuvant chemotherapy. All samples were FFPE samples, so we performed transcriptomic analysis, and each sample was its own control. We dichotomized patients based on two different characteristics. So delta SUV has delta SUV decreased inferior to minus 30, correspond to good responders. And we also use the pathological response according to Chevalier classification, as patients with C3 classification were good responders, whereas non-PCR classified as C1 were classified as non-responders. When we focused on tumor with a delta SUV inferior to minus 30% or superior to minus 30%, we observed that the behavior of tumors after one course was quite different. We obtain delta SUV inferior to minus 30% for 12 patients, whereas 11 patients had a non-metabolic response in accordance with the threshold at minus 30%. So the one patient, the patient number 9, had an almost complete response, so we did not have tumor sample after one course of chemotherapy. And as you can see on the graph, whereas patients that had no metabolic response after one course of chemotherapy had no uniform behavior after one course, patients with a metabolic response had all a left shift of the transcriptomic data after one course of chemotherapy. As you can see, for example, patient 15 had a left shift. Patient 21 also. Patient 16 has a large switch on the left. Patient with no metabolic response had sometimes a left shift or a right shift or a shift on the bottom of the graph, and we do not have a shift at the top. No, I don't think so. No, yes, this patient 13 had a shift on the top. Okay. And when we look at the modification between tumor before treatment and after treatment, in patients with no metabolic response, we can observe that very few number of genes were impacted by the treatment, and only genes that were increased after one course of chemotherapy show significant differences between samples. And these genes were enriched in chemical carcinogens and DNA adducts pathways. To the contrary, in patients that present a metabolic response, we can see that lots of genes were impacted by the first course of chemotherapy. Genes that were decreased after one course belonged to cell cycle pathway, DNA replication pathway, and Fanconi anemia pathway. To the contrary, genes that were upregulated after one course of chemotherapy belonged to the immune-related pathway, especially antigen processing and presentation pathway. That is a very interesting pathway. After that, we focused our intention on pathologic response according to Chevalier classification. We obtained 14 patients with non-PCR and only 6 patients with PCR. Once again, on the left graph, non-responders patients are no homogeneous profile with non-homogeneous shift profile of the transcriptome data. To the contrary, patients with pathological complete response had a left shift after chemotherapy, except for patient 7. So once again, patients with a good response showed a left shift of the transcriptomic data after one course of chemotherapy. Here we observe that, contrary to delta SUV criteria, PCR criteria show that a higher number of genes were impacted by one course of chemotherapy. In non-responders patients, we observe that genes that were downregulated after one course of chemotherapy belonged to two pathways, herpes simplex virus 1 infection and IL-17 signaling pathway, and genes that were upregulated after one course belonged to P53 signaling pathway, Staphylococcus aureus infection, phagosome, and tuberculosis. In GOND responders patients, once again, we observe that lots of genes were impacted by one course of chemotherapy. Among genes that were decreased after one course of EC, we observe that they belonged to homologous recombination pathway, nucleotide excision repair, mismatch repair, Fanconi anemia, DNA replication, and cell cycle, suggesting that genes involved in DNA repair in general were downregulated after one course of chemotherapy in tumor that won't respond to the treatment. When we looked at genes upregulated by one course of EC, we observe that all genes belonged once again to immunity-related pathways, with antigen processing and presentation pathway, natural killer cell-mediated cytotoxicity, and lots of pathway involved in the anti-tumor immune system. Another interesting observation that we did, thanks to the CyberSort software, is that after one course of chemotherapy by EC, we obtained an increased percentage of CD8 T cell based on transcriptomic data. So this increased was only observed in responder patients, suggesting that patients that will respond to chemotherapy increase the percentage of CD8 T cells into the tumor. So now the next steps for the project. As you can see, we have a median follow-up of 55.7 months. We had only 5 progressions, it's good for patients, and 5 deaths, representing not 25, but 20% of the population. We have to test transcriptomic and PFS forecast, and we have to compare RNA-seq data versus PET data to know which one could be the best to forecast PFS. So in conclusion, we observe that tumor reaction after one course of chemotherapy, only one course, could foretell response to treatment or PFS. One course of chemotherapy by epirubicin plus cyclophosphamide seems to get hot some breast tumors, and this tumor warming could be a marker of good response to neoadjuvant chemotherapy. So now we would like to start a new clinical trial with the new standards of treatments, especially the combination between platinum salt and immunotherapy. So to finish, I want to thank Sandy Chevrier, my exceptional technician, and I would like to highlight her fantastic skills in sequencing. And I warmly thank also Corentin Richard for his amazing bioinformatic and statistical analysis skills. So thank you for your attention.